Can you hear me? Can you hear me, Doc?
Hey there.
Oh, you can hear me?
Yeah, that was me. That was mine.
Oh, okay, cool.
Okay. Yeah, I hear you.
Good.
I made you the co-host.
Okay, I gotta leave at 6:15.
Okay, no worries. Just check folks in. In fact, I'm just gonna get a drink. I'll be right back. Don't go anywhere.
Well,
You'll check them in?
you betcha.
Okay.
As long as you did make me co-host. Yeah, you did. Cool. Hey, you. There's Stefan. Hoorah. Hello, Stefan. You're muted.
Hello, guys.
Hey, good to see you. Doc stepped away from the desk for a little bit. And you missed or no, were you there yesterday for Alassa's talk?
Also, no, he didn't talk. It was some other guy, Quinn.
Quinn talked. I mean, yeah.
No, I missed it.
Okay, it's recorded, but I think we're going to have him for Dr. Clearfield on this one.
Oh, yeah, get him on the Clearfield show. I'll try to make that.
Yeah, definitely. That way we can put it on YouTube also. It's pretty powerful. He's got it's a polka. Beats.
Oh, he's into the beats, huh? And he
Onions.
ferments something.
It's beets, onions, carrots, probably apples.
He ferments, I believe.
Yeah, and he said he kept it once in his fridge for about 2 weeks and it did okay. And a lot of his patients are doing excellent on the juice. Just loves it.
Yep.
Sounds like Herosis. That's what you get at Passover. It's supposed to be bricks and mortar, if you know what that is. So it was apples, honey, and something else. Apples, honey, and something crunchy. Like I forget. So it's so what was that? It was some sort of juice or something, Joe?
Yeah, Dr. Quinn's Boca. It's beets, onions, carrots, and I think apple. We were pretty busy yesterday when we were going through what was going on, and I missed a lot of it. But it is recorded, so hopefully Boehmer can send us the recording.
Yeah, we'll see if we can get him on too. So
Yep.
okay, how's everybody doing this week?
Pretty good, but according to Genova Diagnostics Nutri Eval test, I'm dying.
Yeah.
Yeah.
You
You ever run these tests before?
not on myself. I don't want to know. I don't want to know anything.
You don't want to know.
I don't want to know. Yeah, those tests are too scary.
Yeah.
So this, the specimen to run those on would have been my father, Mr.
Oh yeah.
I never met a piece of fruit or a vegetable that I would even touch. He was Mr. Preservatives.
Nice.
So
He probably has a better one than mine.
I'm sure he had better one than mine anyway. So we're waiting for Mike.
Yep. Yeah, because Doc's dad, Teddy, had diabetes, he would use sugar-free syrup on his pancakes. Kid you not.
That's great.
95 years old.
Wow. Legend.
Yeah, he said he wouldn't take insulin. On a good day, his blood sugar was 240. Every doctor wanted to give him insulin, but he said it was made from pigs, and
357.
he wouldn't do pigs. And I say, well, what'd you have for breakfast, Dad? Bacon.
Looks like 350, 157 plus. Is that you, John?
Yeah, I just started semaglutide a week ago. Pretty damn amazing, guys.
Yeah.
I fasted for 12 days. I exercised to my pain limit to the point the pain raised my blood pressure to 227. So being a tough guy didn't work. And none of that lowered my blood sugar. I was still 250, 230 up to 400. Now I got 157 after a week
Wow.
of
Looks like you lost some
Ozempic.
weight. Did you lose some?
So pretty impressive,
How much
man.
weight did you lose?
I haven't lost weight yet. I'm just watching the sugar go down for the first time in a long, long time. And I was a stubborn guy, man. Like I say, 12 days fasting, all the exercise, but the semaglutide went bam, a little teeny bit of exercise and semaglutide. And it's an impressive drug.
Wow.
Just wait. We had one Army veteran who didn't change nothing, diet or anything. He was too busy, and he lost 36 pounds in 6 weeks. We hear stories of that a lot.
Yeah,
No
and I'm taking the lowest possible dose. I think it's a 0.25. Very, just kind of blows my mind, really. I'm just wondering now, what's the bad news? Because I hear that when you lose weight, 2/3 of it can be healthy muscle. What's the story on that?
Muscle and bone. Yeah, you got to make sure you're eating enough protein when you're doing that stuff, because your caloric intake will be like 1/3 of what it is. So everything you consume, it has to be super nutrient dense. You should probably supplement with aminos, maybe a bit of whey protein to make sure you don't lose muscle.
Roger that.
And then talk to Doc. Doc's kind of got this dialed in with
Yeah.
how to stop the rebound. So the people who do the 5-week process, then he stops them for a couple of weeks, and you can go on another 5 weeks, and then you stop for another certain amount of time. So he's kind of got this down.
I'll be asking for advice. Thank you.
Definitely.
All right. So advice.
Hi, Michael Boehmer.
Hello, everybody. Hi, Dr. Burgess. Nice to see you. How are you today?
Likewise. Good.
Hi, Mike.
Good.
Always,
Hi, Dr. Clearfield. Hey.
always good to have you on.
Oh, man, I'm glad to be here. Thank you. Thank you for all you do. Yeah.
And okay, so I think pretty much everybody knows who you are here on
Yeah.
our side. So if not, you can introduce yourself. I'll introduce you. This is Mike Boehmer, and he is the chief clinical bottle washer, or whatever you call yourself, over at Amex Pharmacy in Melbourne, Florida, and they're one of our go-tos for just about everything. So Mike's a fond of knowledge and wisdom, and Amex is great to work with. If you need anything compounded, anything, I mean, I can't ever remember them telling me there's some things that you don't do. You don't do.
We don't do sterile products like semaglutide. That's one thing we don't do.
Right. So, but other than that, anything, he was our savior in the ivermectin crunch, and and lots of other things too. So Mike's going to talk to us today about repurposed drugs, right?
Yes, absolutely. We've been conversing for several years about various different drugs. And so I thought it might behoove us all to do a summary on it. And a lot of this information that we talk about in your group, Dr. Clearfield, and in Halas's group, and also Dr. AJ's group, a lot of these things are gaining broader acceptance. And for example, we've started just within our little group of chronic disease management folks, but now some of the mainstream doctors are treating Lyme disease, and they're kind of stepping in and learning about it, and so people, I think, are starting to come to this kind of information and ask more questions. And as I get asked more questions, I've kind of cobbled together some of the new things and address some of the common questions about these drugs that we're going to talk about.
Mm-hmm.
So let me share my screen if I'm set up to do that. Let's see. There we go. That. Okay. All right, can you guys all see that?
Yes,
Yep.
and by the way, thanks for sending the slides. This is an excellent slide program, so thanks for that.
Yeah, absolutely. My pleasure. Yeah, there's a lot of information here, and I'll go kind of quickly because a lot of this, there's some kind of old news, and then I'm picking up and showing some new things. So, but what these drugs all have in common is they're repurposed drugs, right? What we found is that the pharmaceutical industry often overlooks important clinical uses for a drug. And this can happen for a wide variety of reasons, but it's mainly driven by the new drug application and the FDA approval process, and how basically you make money at big pharma. And you have to have intellectual property that you own, because that's how you get investors. And they estimate the value of that intellectual property, and the people will invest. They'll say, well, it's worth X number of dollars. And then they will find out what they think it'll cost to get a new drug approved. And even if it's an old drug, like an existing drug, like, for example, ivermectin, if you wanted to get an indication to market a product that treated anything other than what it's already indicated for, you would have to reapply and go through a huge investment, which nobody's going to do because the drug is already a generic drug and there is not really a patent available on it. So that kind of makes, as medical science progresses, big pharma really isn't the right party to repurpose the drugs, because they're not in the business of doing that. And so that leaves it upon practitioners, medical educators, and probably compounding pharmacies and other places too, to help advance and point these things out, and maybe help to uncover new uses for these things. So there are major illnesses out there which we know of, and there are new treatments that are needed, but there's not a lot of research happening in some of these areas due to lack of a return on investment. And you could just go through many drugs and look at the examples of this. Tadalafil is a great example. It's useful for things other than ED, but of course, being a smart manufacturer, they decided that was their most profitable indication to get approved for. But there's really many other uses for that, right? And Imiquimod, I don't know how many of you are familiar with that, but it's a toll-like receptor agonist that you can use to treat warts and skin cancers. It treats many other conditions that are applicable to where a toll-like receptor agonist would be effective. So, and this goes on and on, antibiotics, topicals. So as drugs rarely have one action, we want to keep up with this, right? So enough said there. So here's the main drugs that Dr. Halassa and I have really kind of tried to put out there as potentially useful in chronic disease management, anti-aging medicine, and other associated, patient care. Methylene blue, ivermectin, losartan, which is really an amazing drug, low-dose naltrexone, which obviously we know Dr. Clearfield is quite an expert in, and then oxytocin and amlexinox. So these are all FDA approved drugs. And yet they have many purposes other than what we might have used them for in the past, especially methylene blue. Our groups really kind of pioneered this when we started talking about methylene blue a few years ago. I couldn't find any in the United States. I mean, no supplier had it. Nobody knew anything about it. And today it's very popular, and now everybody has it, right? It's become much more popular because people are starting to become familiar with the literature that underlies the reasons to use it. It was used as methylene blue, to look at the big pharma, it was really viewed as a failed antibiotic. People tried to get it approved for use as a urinary, for urinary tract infection, and it got replaced by Cipro. When Cipro came out, it pretty much destroyed any of those kind of what we would have called traditional products. And so it just really wasn't used for anything. But it's a vital drug in anti-aging because, as you know, it's a redox buffer, and redox drives the exposure memory system, mitochondrial function, oxidative phosphorylation, phenotype expression. And frankly, we're under constant oxidative stress challenges from the environment that we live in. And we've had many discussions about how that all happens. Also, you know, photodynamic therapy and methylene blue are really underutilized treatments that are powerful treatments that are easy to do at home, or you can do in the office. We've got thousands of patients on it now, and it's been very well tolerated. I will say that in the past, I believe our dosage recommendations may have been a little bit conservative, and I think dosages could be a little bit higher. And I've learned that by working with a lot of Lyme disease patients who have severe mitochondrial dysfunction, inflammatory problems, and of course, infection. But generally speaking, we've had really no problems. I also have found that the concern over the serotonin syndrome really is fairly rare. And I have a little bit of a protocol maybe I could share with people who want to maybe evaluate a patient with regard to that. So we've just kind of learned more. But doses up to 0.5 milligrams per kilogram daily really haven't caused any side effects that I'm aware of. We have people now getting close to 1 milligram per kilogram with some of the Lyme disease. And at that level, you start to see things like nausea, or people maybe have a reaction. But that's far, far higher than we really thought that threshold might be. So really, I consider that the upper threshold of what anybody should be taking daily. The basic anti-aging protocol would be 0.5 milligrams per kilogram, which would be 5 to 25 milligrams twice daily, ongoing. Mitochondria function 24/7. And, maybe an occasional break here and there is a good idea. So people have recommended to let the body kind of build some oxidative stress. But I think that's really patient specific. It depends on the patient, their condition. For mitochondria and neuroprotection, 0.5 is basically the same dosage. And then using conjunction with the other items that we talk about as a cocktail, right? Your NAD and your CoQ10, methylene blue, NAC, glutathione. These are all fuel for oxidative phosphorylation. And as you all know, the enzyme function is crucial. So you can stimulate those with exercise, phototherapy, ozone, hyperbaric oxygen. And some people in our group actually like nebulized hydrogen peroxide for this purpose. Oral care, don't forget methylene blue is actually very good for oral care for people with really bad dental problems. We've talked quite a bit about the severity and the impact of dental or latent or non-symptomatic dental infection on health. And it's actually a major cause of disease. Most doctors probably aren't going to be able to do a dental exam or ascertain whether or not a patient has these things without getting a dentist to weigh in and do the exam. But I think, methylene blue can play a good role there with the red light because it destroys infected cells and it can reach up underneath the tissues where the light and the methylene blue are present, but would not be accessible to, say, a mouthwash or some other form of treatment. Lyme disease is really something that I had not worked much with regard to methylene blue. And methylene blue is a very important drug in the treatment of Lyme disease. If you look at the studies associated with it, it's a great, it has a synergistic effect with azithromycin and rifampin, especially, and other antibiotics. And it has its own intrinsic effect as an antimicrobial. So it's just especially effective against these particular pathogens, partly because it probably penetrates biofilm. So they're using higher dosages. I've conferred quite a bit with members of the ILADS group, the Lyme International Lyme Group, and this is kind of where they're at on that protocol.
Mike, real quick.
Yeah.
Missed on the oral care. It says MB with PDT. What's PDT stand for?
Photodynamic therapy. remember the red light? It's like a football mouthpiece that you could get. And Dr. Hepburn, who is a member of our group, actually designed and sells one for $99. It's very cool. You put it in your mouth, press the button, and it irradiates your mouth very brightly with red 660 light, which is the proper wavelength for photodynamic therapy with methylene blue. So yeah, that can be a therapy that really can treat infections deep in the tissues. And that's hard to do, especially without a lot of antibiotics. But Epstein-Barr flare-ups, that's something that in CMV, we're seeing that after post-COVID, the viral infections can also be controlled with methylene blue and PDT. This is the same process that's FDA approved to kill these viruses in blood banks. They irradiate the blood with methylene blue and red light, and that kills all of the viruses and pathogens in the bag. So that's how that's done. It's the same process. Grant you that if you do it in your own office, it's not as controlled as something that a blood bank would use, but the process still is the same. One area where I think we aren't using methylene blue much is in neurodegenerative diseases. And my purpose here tonight is more to talk about the drugs and their uses as to go deeply into the reasons why for these uses, because we've kind of addressed that in other lectures, and we could go further into that. But there is a tremendous bunch of literature on methylene blue and mitochondrial function in general as the root cause of neurodegenerative diseases. And that would be like Alzheimer's, that would be like dementia, that would be post-TBI injury. Mitochondrial function is crucial to combating inflammation that's in the brain for whatever reason it is there in whatever particular condition. And this has really been shown to preserve the functioning of these neurons and prevent their death. And as we know, the brain utilizes a ton of oxygen, but it cannot store energy. So it relies on a constant blood flow, and it relies on plenty of oxygen being available to the mitochondria. And when this isn't happening, you lose brain cells. Mitochondrial dysfunction leads to inflammatory signaling that damages neurons and can result in physical changes to the brain itself, leading to neurodegenerative disease. So so the root cause of Alzheimer's disease, as we understand it today in the literature, appears to be it's an oxidative stress or inflammation-related illness. It's not caused by the depositing of these proteins. The proteins are deposited as a result of cellular dysfunction. Cell prevention and early treatment of these diseases must be far more effective than any after the fact treatment, right? Because there's physical changes involved. So, if you wait till later to treat it, it's kind of a bit too late. I would advocate for methylene blue to be part of any prevention therapy for a person, suspected of being in the process of developing any of these neurodegenerative diseases or after a traumatic brain injury. Certainly something to really look at. And again, it's safe. It's an FDA approved drug. And there's a ton of literature behind that. Methylene blue also in Lyme. This is a really new thing. If you're not treating Lyme disease, or if you are treating Lyme disease, I guess I would say, and you're not using methylene blue, you should really give it some thought and look into it. It's a great adjunctive therapy. Of course, there's no one medication or protocol or treatment for Lyme disease. It's a difficult and complex illness to treat, but methylene blue's got direct antimicrobial effects, synergistic effects with key antibiotics, and then you're getting energy support, redox, anti-inflammatory, neuroprotection. These things all fit like a glove with what you would want to be doing for your Lyme disease patient. It has a role in all of the phases: the acute, disseminated, and late inflection, and the flares. And photodynamic therapy is really helpful in flares if you can adequately detox the patient and do that kind of in a pitch and catch type of scenario where you treat, then you detox, treat, and you detox. Higher dosages are used for Lyme as compared to general anti-aging. We should use the lowest dose of a medicine that we can that's effective. And I think for Lyme disease, these folks should just have a chronic illness where a patient, with general and anti-aging patient maybe or something might not. So they start really at 10 milligrams twice a day, and they titrate quickly up to probably about 25 to 50 milligrams twice a day. So the most common dose seems to be 25 milligrams twice a day, 30 milligrams twice a day. And then beyond that, you should probably exercise some caution, especially with regard to the weight of the patient. It is okay to use it with high dose vitamin C, with ozone therapy, with hyperbaric oxygen or PDT. So there's a lot of, I don't know what you might want, a host of different therapeutic interventions that go with it. That are some of them are in office, and so the idea that's kind of come up is you can put a patient on this, leave them on this cocktail of a kind of a nutraceutical cocktail, and then when they come in the office, you can give a kicker dose to manage flares or to give additional treatment as needed for when, like, for example, test results are showing, there's a flare up in process or something like that. So there's a lot of treatments that it goes with. One thing that's come to my attention is that whenever you do these IV therapies, it's a good idea to replete minerals, magnesium, and the NAD, NAC, glutathione kind of triad to help eliminate toxins. And so that's kind of been something that's been brought to my attention as important. Excuse me. We now, when we talked about and as I think Joel mentioned, I just wanted to put a quick slide up. This is the device that was created by Dr. Hepburn, who attends each of our groups at different times. She's from the Bahamas, and she's an expert in phototherapy. She's actually a dermatologist. But this is actually from her website. It's kind of a lousy slide, so I apologize, but it shows how bright the light is. You can see it through your face in a dark room. So it's really irradiating the teeth. You can see the roots of the teeth there. So, that could be a beneficial therapy to folks that need it. So as you already know, the guys that go, the friends of methylene blue are the other mitochondrial stimulants or mitochondrial fuels. And then with regard to Lyme disease, azithromycin and rifampin have a special relationship with methylene blue because they have a special synergy for antimicrobial. Ivermectin, we know, goes well with methylene blue and has been used a lot. So that's a completely safe thing to do. Same with low-dose naltrexone, red light, and vitamin C. The main point here is that I have witnessed and worked with all these medications with quite a number of patients, and we've not seen problems. So I wanted to pass that on. And I also will post a protocol for in-office use of methylene blue with ozone. I've gotten that from a very interesting guy named Dr. Levy, Thomas Levy, who lectures on ozone therapies. Now for IV use, you want to put it in D5. We've kind of talked about maybe using, normal saline. I've really come to the conclusion that's not advised. So it really needs to be D5. A 250 bag is a good size. The vials or the bags should be at room temperature before use. If you put methylene blue vials or pre-made bags into the fridge, you can affect the solubility of the medication in there. I don't really think it's a problem, but we don't want to have clumping or anything due to solubility changes that are temperature related. So let them come back up to room temperature before use, shake them up good, and you're good to go. I probably don't need to say this, but if you've not ever worked with methylene blue or you've ever spilled any of it, you realize how sorry you are the second you do it. It's highly staining, and it may permanently stain things if you spill it. So if you're working with vials of methylene blue, you know how you can be drawing something up and a little drippy drop will come out the thing. Be very careful of that. If it will fall on the floor, it can stain your carpet, all that kind of stuff. Always use sterile technique when you're handling vials. And, don't store a punctured vial of methylene blue longer than a day or two in the fridge. It's not a preserved drug. It's intended for, quote unquote, immediate use, which is kind of 24 to 48 hours. So if you're going to save a vial for a patient the next day, like you're going to use half of it today and half of it tomorrow, just wipe the top with alcohol, maybe put it in a little pharmacy vial or a little baggie, put it in the fridge, and you should be okay for a couple of days, but really not beyond that. The questions come up about wasting a vial, right? The patient comes in and we need 20 milligrams out of a vial, and I don't have another patient till 2 weeks from now. What do I do? Well, what you can do is you can make up additional bags in D5, and you can freeze them for up to 30 days. And you have to thaw them, of course, the night before. So you do have a little planning and logistics to deal with, but at least you're not wasting your medicine that it isn't super cheap. So you can, shoot the extra bags. So let's say you made up 5 20 milligram bags, you freeze 4 of them, you use 1 today, and then you use 1 each week for up to 30 days or something like that. So that's I think the best solution to that. I'm not aware of anybody that has methylene blue sterile in a vial smaller than 10 ml. So that question is there 1 ml vial or a 2 ml vial? And I'm not aware of that. Important to be at room temperature. We covered that. You can use a filter, and a 20 gauge butterfly is typically what people use. If you want to use a filter, you can. There's really not a reason to if your product has been made correctly. But if it was frozen, thawed, and you thought it wasn't quite up to room temperature or something, best not to give it. But if you were to do that, maybe a filter would be wise. And then you always want to hang your bag of methylene blue separately and administer it separately. It doesn't, you don't mix it with something else, So that's really all I had about updates on methylene blue. But it's been a very interesting drug to learn more about. And I'm going to kind of go through ivermectin. This is interesting. We have people using ivermectin now for other purposes than COVID. Whoops, excuse me. And so and we've also had Dr. Halassa talk extensively about the immune, kind of the pillars of chronic disease management being redox, metabolic, immune, and then regenerative. The immune functions of ivermectin have been a little bit cloudy, right? Like, what are these anti-inflammatory / immune functions? So I wanted to talk tonight about purine receptors and some of the other mechanisms that kind of backfill some of the information that we've talked about methylene blue is having these effects, but maybe not talked about why. So ivermectin in general, I think we're going to have more uses for it. And we've discussed it extensively, but some new info has kind of come up. Now, the main action of ivermectin in all cases is an allosteric modifier. So if you imagine a molecule that has 4 branches on it, right? So imagine outstretched arms and legs, and it kind of looks like that in a rough way. And each one of the hands and feet can attach to a protein just through normal, chemical, reaction or chemical attraction. And by doing so, they can block intracellular membrane pores. They can block pores or transport across the membrane by blocking various, I guess we just call them transport mechanisms. And there's transport mechanisms on every membrane, right? They're at the mitochondrial membrane, they're at the nuclear membrane, they're at the cell membrane between the cell and the outside. So they're all over. And some of these are blocked or reacted with by methylene blue. So an allosteric modifier basically means methylene blue grabs onto this protein, and because it's attached to it, just simply because of that, it changes its shape and may not function anymore. So the effects of ivermectin are related to that always. It seems like I haven't seen anything different, but we're going to show you some different reasons how that's working. And for example, in COVID, it had multiple mechanisms against COVID, and they were all really related to allosteric modification. And we know that it modulates the immune system, it reduces interleukin-6, and it helps to move immune or T cell polarization away from Treg and Th17 more towards Th1 or maybe Th2, depending on the situation. And that process of ivermectin occurs through these P2 receptors. And we're going to go over that a little bit. These exist on microglial cells and macrophages mostly, but also other places. And they actually regulate the immune system's function in relation to the central nervous system. In addition, ivermectin's got some anti-cancer effects. I don't know if any of you are working with Manuel. I've forgotten his last name, but there is a WhatsApp and Viber group of people working with ivermectin in prostate cancer. And some members in our group have worked with this, and I've worked with them. And as far as I can tell, the anti-cancer effects are immune, but they are also by a blockade of this FOXA1 enzyme, which increases the mitochondrial reactive oxygen species in cancer cells and stimulates autophagy in tumors. So we're going to go over those real quick. Now, one thing I was curious about, Dr. Halaz always says, ivermectin, decreases interleukin-6. Well, I did not know why, okay, or how it worked. And it's a direct effect on the receptor. And you can see where ivermectin here, we have an interleukin-6 receptor, which interestingly note is like a membrane pore, right? It's a protein embedded in the cell wall that allows interleukin-6 to pass through and enter the cell. Now, when interleukin-6 comes into the cell, this process basically says, we have interleukin-6 here. We better make interleukin-6 ourselves. And, and that is a process that dependent on this PAK1 and Janus kinase 2. So by blocking that effect, essentially you make it so that cell will have interleukin-6 enter the cell, but that cell then won't respond and create an amplified, amplify that effect by secreting more interleukin-6 itself. So that was interesting. So that's the PAK1 receptor pathway. Interestingly, it has Janus kinase as a modifier, but this is Janus kinase 2, so I don't think it's the one that we typically work with. But otherwise, it's just operating through the normal nuclear factor methodology. So how does it promote autophagy? Ivermectin does promote autophagy, and interesting, that's related to PAK1 too. So you can see that ivermectin can bind to this PAK1, and then acting as an allosteric modifier, it's unable to do its job basically. And in this case, you can see it's related to two different processes. One is a PAK1 mediated process to create proteasomes, and then another one is an mTOR related process that results in an autophagosome. Okay, right? Like I don't know who made that up, but a little inflammasome type of like deal that is carrying proteins out of the cell in autophagy. So those are the mechanisms where ivermectin is promoting autophagy, suppressing interleukin-6. So moving on to why does ivermectin have an effect on the immune system? Well, that's because of P2X receptors. P2X receptors are ATP activated. They do nothing unless they sense ATP. But if they sense ATP in their environment, and of course where they're located, there's not supposed to be any ATP free, they act, and they're extremely inflammatory, because they're basically saying a cell has blown up nearby me, and I'm indicating that there's way high levels of ATP. We better there's damage in the area. It's like a what do they call it? I forgot what they call it, but like a catastrophic signal that goes out. And so P2 receptors, especially the P2X4 receptor, regulates neuroinflammation signaling and it actually kind of controls the P2X7 receptor. And interestingly, duloxetine and paroxetine are antagonists of P2X4 receptors, so they are affecting the immune system. And when we talked about antidepressants and inflammation, this is one potential way that they interact. But you can see that P2X4 receptors interact with endothelia, with monocytes, macrophages, microglia, eosinophils, mast cells, B cells, and T cells. So there's a profound interaction between these receptors. When we activate them, we're going to get mast cell degranulation. We're going to get leukocyte activation. The effect on B cells is unknown. T cells, you're going to have impact on mitochondrial metabolism, cell migration, immune polarization of T cells, which is we're going to talk more about. And so it's affecting some really crucial inflammatory markers, just in the same way that the the angiotensin 2 receptor kind of really has a lot of impact. It's a very important receptor pathway. So these are looking pretty similar to that in terms of their scope. So P2X4 receptors are part of the neuroinflammatory axis responsible for neuron repair. You have damage to neurons, we're going to have activation of P2X4 receptors because they see that ATP, they go, that's not supposed to be here. What's happening? We better, send out the alarm for, to create more inflammation. There are also other P2 purine receptors that create an interface between the immune system and the CNS. And these, help to regulate things like inflammation and apoptosis in the CNS. So there could be, some anti-inflammatory effects here with ivermectin. And frankly, really, I'm trying to open the door possibly to other drugs that we might look at that influence these receptors as we learn about them. So ATP gated, and they're on microglia astrocytes. They release pro-inflammatory cytokines, chemokines, secondary inflammatory messengers. And interestingly, the P2X4 receptors in the endothelium and the circulating immune cells, they actually help regulate crosstalk between the immune cells and the central nervous system. And I found that fascinating, right? So we're sending a signal for inflammation, but we're also in another area going, well, I don't know, I'm not sure that's exactly true. Let's look into this more. So it kind of tempers the reaction because it is potentially such a severe reaction. It's also, these receptors are also involved in neuropathic pain and allodynia. And then, of course, as a final point, P2X4 receptors help regulate P2X7 receptors, which actually are even more impactful. And so P2X4 modulates P2X7. They're like two guys that bind together, and when they bind together, they make like an activated complex. And again, they sense, that's the word I was looking for before, they sense danger signals. And that's ATP, which is considered a danger signal. And then what do? They increase inflammation. They increase inflammasome production. This complex here is an inflammasome, basically, a Cas-based inflammasome, the NRLP3. And then we end up over here with pyropoptosis and inflammation. So basically, it's a signal where a necrotic cell signals a cell nearby to it to say, you might want to fold up shop here. Things are looking pretty bad. And so that's bad kind of inflammation, right? So what are we looking at there? We're looking at interleukin 1 beta, interleukin 18. And these guys are crucial to the functions of P2X7 receptors on the immune system and on inflammation. And we're going to look, when we look at losartan, we're going to find out that interleukin 1 beta is a nasty fibrotic bad dude. Let's see. So the P2X7 receptors reside in the cell wall, and they monitor ATP levels inside and outside the cell. They're ligand-gated ion channels that open a pore in the cell wall and participate in cell destruction or preservation by manipulating the concentration of ions. And these are not like calcium channels or potassium. They're like everything. Okay, they just open up the door. That lets in a lot of crap into the cell, and that it's almost like the cell's dying, it just opens the doors. ATP is not normally present, okay, so that indicates danger. We covered that. ATP turns on. So the other thing is these receptors are dormant most of the time. So unless there's an injury or a danger signal, these receptors don't do anything. Or that's the thought that I gathered from literature. They basically are dormant, and then they only react when they are needed. Now in cancer and infectious diseases, activation of P2X7 receptor, they call it an angel or demon effect, because it depends on the level of activation and the cell type where the whole deal is going down. There are contrasting effects. So it depends on how much activation there. So in that way, it's like mTOR or something, if you activate, well, mTOR is more like a switch, but if you activate it, there's a sweet spot of activation that is beneficial. And then there's beyond that, it's highly negative. And then neuroinflammatory or neurodegenerative diseases involve activation of these receptors. And they've shown that activation of P2X7 receptors is a factor in the disease progression of neuroinflammatory diseases. So when they test people who have increasing activation of this system, they see more severe symptoms of their disease. So likewise, by backing that down, we would hopefully be reducing the impact of the disease. So note that when I said that these drugs, a lot of them go together, when we talk about methylene blue and its actions for neuroinflammatory diseases, there are possibly some reasons that ivermectin would be helpful in some of these. Here's a very interesting complex slide, which I'm not going to go over the whole time or every little detail of it, but it really lays out this process and of danger signaling, and it involves these P2X7 receptors. But it shows here how you have activation of NF-kappa B, activation of pro-inflammatory cytokines, creation of inflammasomes, all kinds of nasty stuff. But again, the key is interleukin-1 beta and interleukin-18. These are guys that really go out there and create further problems. And then if you really look at the damaged excessive response over here, what we see is more and more cells in that piece of tissue die. And there's more, and an ever kind of increasing triggering of immune function. So that's, I guess, the point of that slide. And of course, we could really probably dig into that and read a lot more, but for the sake of time, I don't want to go too far with that. Ivermectin in cancers is being investigated actively for prostate, breast, and colon cancers. Each type of cancer involves different cells and different crucial biochemical pathways. So the mechanisms are slightly different due to the different type of cancer and the different tissue, but they're all relying on the allosteric modifier effect of ivermectin on the proteins and enzymes that are involved in some crucial biochemical process related to that cancer. The effectiveness in specific cell lines is confirmed, like people have cultured these cancers and shown that ivermectin has effect against them, but they haven't really worked out completely what all of the reasons why are. But in general, it's blocking a crucial step in cellular function for that cancer type, and also promoting autophagy and apoptosis. The immune effects then are, of course, modulated by purine receptors, right? So if we're suppressing those purine receptors, we're suppressing the cellular danger response and tamping down inflammation at the cellular level. And then we also have, remember we discussed the PAC1 early in the conversation about ivermectin. So there are other mechanisms as well by which there's a favorable effect. So, and then we had the FOXA receptor pathway. And essentially, this is also promoting apoptosis in the tumor. And it's essentially blocking the functioning of this FOXA, which is inducing the production of genes that, that are tumorigenic. So by blocking that, we're promoting apoptosis is the bottom line. So that's what I had to know about ivermectin. Nothing's changed with regard to dosage. I can tell you some of these cancer patients have pushed the dosage to 100, even 200 milligrams a day. Some patients aren't able to take that. You know, they have a protocol to determine kind of what the maximum dose that patient can take is. They try to keep them at the highest dose they can. You know, but they're getting some good effects. So I would like to at some point bring Manuel back on here and get a report back from the doctors that are part of this work. And I will tell you, the patients are it's an expensive treatment, and some of them get amazing results, others don't. So it's certainly not a replacement for the proper traditional therapies, but it surely can maybe provide an additional effect. Okay, so we're going to pivot a bit and talk about losartan. If you need a blood pressure medication, I'm going to recommend you try losartan if you can take it. You know, it has a potent anti-fibrotic effect, and we don't have a lot of treatments for that. And as you know, fibrosis destroys or damages the functionality of tissues, and it's difficult to treat once it's occurred. It's essentially scar tissue, right? Unbelievably, losartan has been shown to reverse fibrosis in the eye, liver, kidneys, and muscle tissue, and reduce tumor and stromal pressure in cancers. And it's doing this basically due to its functioning to suppress the angiotensin system, which is at the center of the fibrosis. Angiotensin II is a pro-oxidant fibrogenic cytokine. It's interesting that this study quoted here refers to the angiotensin II molecule as a cytokine, pro-oxidant and fibrogenic. It upregulates other pro-oxidant signals such as TGF beta 1, right? Which we see it was also, oh no, it wasn't, never mind. But TGF beta 1 and is blocking the regulatory or regulating the overactive angiotensin II arm. So there's a lot of good reasons to block the angiotensin II type 1 receptor. So angiotensin II type 1 activation, that's all the bad stuff: vasoconstriction, fibrosis, ventricular hypertrophy, aldosterone and vasopressin release. It's just going to clamp down blood vessels because you know, it's part of the healing process, right? When that receptor is activated, it says there's damage in the area. We're going to have to get busy and produce tissue here to patch up the larger tissue. Now, the angiotensin II type 2 activation is just the opposite. It's vasodilation, anti-proliferation, neuronal regeneration, anti-atherothrombotic, you know, so it has effects on the endothelium. So basically, by blocking the angiotensin II type 1 receptor, we are allowing the angiotensin II type 2 receptor to become the dominant effect. So that's the mechanism of action for losartan in most of these cases, and including blood pressure reduction, right? Because we get a net vasodilation because we've turned off the source of vasoconstriction. Unfortunately, the fibrosis part, and interestingly, if you think about this, high blood pressure then inherently is probably a sign that there's fibrotic activity going on in the body. And if you look at the RAS system here, and I know Dr. Halas has described this similarly, when you block the angiotensin II type 1 receptor, you're basically enabling this arm over here to do. Now, normally in the body, there's a balance between these. But medical conditions of various types can dysregulate this system and make it lean towards vasoconstriction and fibrogenesis and pro-inflammatory, and raises your blood pressure. You know, so this is a good system to not have out of balance and overactivated. And of course, we saw in COVID that was highly overactivated, and there was significant fibrosis associated with people who really had high viral loads of COVID. There's a broad base of literature discussing the antifibrotic effects of losartan in the kidney, in the liver, prostate, heart, lungs, eye, and even with diabetes and fatty tissue. This is because the angiotensin II receptor is prolific, pro-inflammatory signaling that is in response to injury. So it's related to repair functions like fibrosis, proliferation of cells, healing, the extracellular matrix, tumor stroma. It increases the production of these things, because it thinks there's been an injury and this needs to happen. But it can be over-signaled incorrectly, and result in these problems. So each specialty has, and we notice there's all these different specialties are involved in the treatment of these conditions, and they all kind of, again, refer to it their own way. But I'm going to go over a couple of interesting ones with you. So a hepatic fibrosis, there's these stellate cells, which is essentially macrophages that are in the liver, and they're sensors. And when they perceive inflammation or injury to the endothelium in the liver, they start doing all these things, right? They start, and at the end of the day, they activate myofibroblasts. So that's the problem. The myofibroblast activation is what's behind things like ocular fibrosis and liver fibrosis, liver damage, cirrhotic liver. These things are all caused by overactivation of these myofibroblasts. So by dialing down that system and reducing the activity in production and activation of these stellate cells and myofibroblasts sucked down the stream, then you're preventing fibrotic activity. Kind of the same thing is talked about over here. I guess it's just kind of a backup slide, but I think this is the pertinent slide. And the key aspect of this is myofibroblast activation, because that's really not what we want. So this is an example of the stromal, or not a stromal cell, I forgot what the stellate cell. This is the liver. This is endothelium. This is the blood. This is this space of dis, they call it, I suppose. And this is this little gap of I guess cytoplasm in there, and that's where these stellate cell macrophage guys live, and they're sensors. So when they perceive an injured hepatocyte, they basically receive that signal, and they regulate all kinds of craziness in the immune system. And we could again go over each of these and really create a whole presentation out of this slide that would be fascinating. But essentially, they're all super pro-inflammatory and fibrotic, and we want to prevent that signaling if we can. And you can see that losartan is effective in that area. Renal fibrosis operates through sirtuins. Losartan also kind of induces sirtuin-1 activity. And what that does is sirtuin-1 apparently regulates anti-inflammatory enzymes. One is that HO1, which is heme oxygenase. So when there's heme, free heme, or blood, basically destroyed red blood cells, that is a hyper-inflammatory thing. So by upregulating this heme oxygenase, you're clearing those free radicals that are in the bloodstream due to damaged red blood cells. Thioredoxin is one of the key anti-inflammatory or antioxidant enzymes. So upregulation of that is a positive. And interestingly, renal fibrosis is regulated by endoreticulum stress. So sirtuin-1 reduces renal fibrosis and reduces apoptosis, and it's helping to increase cellular life, right? Prolong the tissue. Stress in the endoplasmic reticulum elicits NF-κB response, and then the NRLP3 inflammasome activation, maturation, and then we get a relief of all this bad stuff, we end up with collagen, TGF beta, and fibrosis. So sirtuin-1 reduces that oxidative stress and damage to the endoplasmic reticulum. So that apparently is the mechanism that they have described in renal fibrosis. So low sartan can impact that. The one that really surprises me, so this would be maybe a reason if you had to select a blood pressure medication that low sartan would be a good idea, or if you have people facing any of these illnesses already, if they're able to take low sartan for some reason, if they're able to tolerate it, it would be possibly a good intervention. And it's a $10 intervention, very cheap. The eye is just amazing. Corneal scarring can be reduced, or I'm sorry, reversed, prevented or reversed. The scarring or deposits are caused by those myofibroblasts, and TGF beta signals to, activates those myofibroblasts, right? So when we look at those liver stellate cells, one of the signals they send out is TGF beta, and that basically promotes the action of these myofibroblasts in the eye, not in the liver, but same mechanism, and it promotes them in the eye, and we get this cloudy retina. And they actually have drugs that are anti-TGF beta. They know that this condition is, dependent upon a constant secretion and inflow of TGF beta. But the problem is that the TGF beta drugs are large. I guess they're probably peptides or some kind of MIBs or MABs, and they specifically target that cytokine, but they don't penetrate the eye very well. And you get an incomplete effect, I guess, because the deeper tissues, if are affected, the treatment doesn't really reach to that penetration level. Although sartan is a small molecule, it's water soluble, and it does. So a dosage of 0.8 milligrams per mil 6 times a day for 90 to 180 days reduces myofibroblast development, which is dependent on TGF beta signaling, and it just reverses the condition. It's quite surprising. So I think this is a new therapy. I'm aware of a couple compounding pharmacies that do make these, and there's some major institutions, working with them on this. So low sartan is contraindicated in pregnancy. The oral dosage is 12.5 minimum. It's just once a day. Really, the normal therapeutic dose is given as 50 milligrams, and people seem to take 50 to 100 milligrams for blood pressure typically. It's very inexpensive. It's literally under $10. If you need a blood pressure medication and you have any kind of chronic inflammation, it seems like a good choice. So you can see how we're kind of developing a group of drugs that kind of can work together. And I don't see what my time looks like. We got a couple more drugs. Low dose naltrexone, I know, is one of Dr. Clearfield's areas of expertise. The way I approached this was by looking at the effects of opiates on the immune system, and then looking and comparing exogenous opiates like, say, morphine or hydrocodone or oxycodone with the effects of the endogenous peptide opiates, such as endorphins and kephalins and such. And so really, in my mind, the way that low dose naltrexone is working is it's suppressing opiate receptors. It recepts 3 different kinds of opiate receptors are suppressed or blocked pretty completely, actually, by naltrexone. And although we only block them partially for a period of time each day, and then this creates an sort of overproduction of the natural opiates. And the natural opiates have a different portfolio of actions against the immune system than exogenous opiates. So I found that interesting. And that's really kind of the one of the reasons that low dose naltrexone works, is by stimulation of your endogenous opiate system. So this enhances immune function, reduces inflammation, downregulates Th17 polarization via a decrease in IL-10 and TGF beta. So TGF beta helps to polarize the immune system to Th17, which oftentimes isn't helpful, in infectious diseases or cancers. Low-dose naltrexone is an underutilized therapy, I believe. Not too many doctors know about it outside of groups like ours. So the therapy is not well understood by those folks, and they don't understand that it works differently than high-dose naltrexone. I'm sure Dr. Clearfield has had, or many of you others have had calls from doctors going, "Why is my patient getting opiate therapy from you? Opiate abuse therapy or something?" So a lot of people just don't know what it is. Which is a shame. It can be used to assist in the treatment of fibromyalgia, multiple sclerosis, Crohn's, ulcerative colitis, Hashimoto's, weight loss, traumatic brain injury, cancer, Hailey-Hailey's disease, and a host of other dermatologic conditions that are rarely discussed. I don't think dermatology uses any low-dose naltrexone that I've ever seen, or naltrexone of any form. Chronic regional pain syndrome, chronic pain. I got something under here. I can't see it. Let's see. There we go. Sorry about that. Oh, spike protein in COVID. It's been pretty effective for some folks with that. And so there's no labs or special exams needed, but you do need to know how to titrate the dosage up, which is pretty simple. One thing I've noticed about dosage titration is that if you titrate too fast, you have the potential to not realize when the patient reaches the threshold of effectiveness. And what I mean by that is the threshold, you may need to be at a particular dosage for a week or 10 days before the patient senses a response. So if you proceed through it too quickly, essentially what happens is you just go straight to 4.5 milligrams, not knowing if 3 was going to be enough. So I've kind of noticed that where a few people have had to back somebody down to a lower dosage. So I wondered about the speed of titration. Everybody does it different. I really would say that the prescriptions we receive are pretty different in that process, but they're all generally similar. But if you go too fast, you might not actually know, or the patient might not actually know when you hit the target. The other thing is I found in literature that you really kind of need to leave a patient on it for 6 months or more to really fully assess whether it's going to be a good long-term therapy for them. But you really, shorter time than that, you really don't maybe learn how well it's going to do. It can suppress thyroid function, and there's recommended to check a thyroid stimulating hormone after a few months. Patients frequently report favorable responses, and I'll show you that. Low cost, readily available. So basically, it's a short-term nocturnal blockade of opiate receptors, and that leads to downstream effects that cause the therapy. The side effects are low. Insomnia is the most common thing. I've had some people complain of the vivid dreams. I've not really heard a lot about these other ones. Thinning hair, loss of appetite. I just don't get reports of that, but that's probably not something people would report to me. So Dr. Bill probably would know about those things. Interestingly, look at all these skin conditions. I mean, some of these skin conditions are really hard to treat. Lichen planus, lichen sclerosis, these psoriasis, these are all serious illnesses that no dermatologist wants their patient to have walk in their door. Vitiligo, pyoderma gangrenosum. These are all really terrible dermatologic conditions that are hard to treat. And I tell you what they do, they slather clobetasol on them, and then they ask for double strength clobetasol. So that's not probably the best way to deal with that. So I would think, hopefully, we can slowly convince our brothers in dermatology, or brothers and sisters, to look a little bit at low-dose naltrexone, as well as for mood disorders, PTSD, thyroid. We know we heard Dr. Bill speak extensively about Hashimoto's thyroiditis and low-dose naltrexone. So a lot to think about with low-dose naltrexone. And this slide, I don't think this is from Dr. Clearfield's presentation, but he has a similar slide showing that the majority of patients do well on it and like find it improved. And a small number of them may perceive no change, but few of them feel that they're getting worse. So that's a pretty good profile for a drug. The mechanism of action is twofold. It inhibits toll-like receptor 4, and then that impacts the innate immune system, right? Because toll-like receptors are attached to our innate immune system, and they basically induce or suppress the or regulate cytokine production. Endogenous enkephalins and endorphins that are triggered by the low-dose naltrexone protocol lead to an enhancement of the immune response, reduced inflammation, and downregulation of oncogenes. And then again, over here on the, and I guess we would call that the effect on the not the adaptive immune system, right? But our home system that's regulated through toll-like receptors, that leads to a lot of good things. We're downregulating Treg production, which we've already noted that we're downregulating Th17 polarization, which is good, and reducing IL-10 and TGF-beta. So nobody likes any of those guys. That's a good thing to help reduce those. And again, that's by reduction in toll-like receptor activation. So these are all very, very good effects. Oh my God, I don't know if I can even read that slide. It's kind of a repeat of the last slide, but if we could read it, it kind of outlines some of the positive effects. I guess we can't see it too well. Now here's another really good one. And I've never heard of methyl naltrexone, but I think that could be something that we see as a drug down the road because it seems to have some pretty positive effects. These slides are comparing the effects of low-dose naltrexone with methyl naltrexone. So I'm not going to go into methyl naltrexone, but this was a good summary of all the different things that we're doing, and I won't go through each one. But if your patients are suffering from conditions that are related to any of these cytokine profiles, we're going to be doing a lot of good things with low-dose naltrexone. And I'd also point out that by blockade of the mu-opioid receptor, that is the mu-opioid receptor being activated suppresses the immune system and allows tumors to have a more favorable environment. So the mu-opioid receptor is something we really don't want to have triggered by exogenous opiates that are super good agonists for that receptor, because there's a lot of immune suppression and immune malfunction that comes from the use of opiates. I did not realize how bad opiates are, but our opiate epidemic, which hopefully we're getting through to some degree, really made people much more sick than just their opiate addiction. I mean, there was tremendous effects on their immunity and their other systems. So where do we find opiate receptors? We find them basically all over the body. And I don't know for the sake of time if we need to go through all of these, but I've put all these in there and really broken down where the opiate receptors are and where each subtype, which is your mu, sigma, kappa, delta, zeta, and nociceptin. Those are all your opioid receptors in your body. So I kind of broke them down by what they do. But the bottom line really is when you look at it, the opiate receptor system definitely interacts with the immune system by dialing down inflammatory response, because that's part of how it helps to provide analgesia, right? It reduces inflammation and immune cell activation, and but that can be a bad thing because it also is suppressing your immune system from doing jobs that it should be doing. So interesting that the main point, I guess, rather than dig too deep into it, is to show that all these different receptors exist, and our endogenous opiate system utilizes all these. And really, the mu-opioid receptor is what's utilized by exogenous opiates. So we're triggering all these to be activated when we use low-dose naltrexone. And again, you just see this profound portfolio of effects, and this is why it's a medication to maybe try for a wide variety of different illnesses, considering that there's not a lot of drawbacks to it. So I guess I've already made this point. Endogenous and exogenous opioid agonists and antagonists have different effects based on receptor binding affinity and the location of the receptors. Exogenous opioids are immunosuppressive and likely part of the analgesic effect. This predisposes patients to opportunistic infection by suppressing Th1. So if you have an infected patient with bacterial infection, opiates are not the best thing to give them. You're suppressing their Th1 immune response. Endogenous and exogenous opiates act on different primary receptors. Naltrexone is an agonist for mu, delta, and kappa. So those are the ones we're really activating mainly when we suppress the opiate effect, but that's not really what the response is on the endogenous opiate side. We get a more complete portfolio of all the opiate agonist peptides. So note that opiate therapy down-release Th1 promotes Th2 and Treg and Th17. So it's very unhealthy. So I guess that's about it that I would really say about opiates. Let's see. I'm not going to go further, I think, on some of this. I provide some other details in here on the slides. You can go over them, but it's kind of looking at the opiate system and what all it does, and explains the effects of low-dose naltrexone in terms of what actions our endogenous opiate system has. And this is really a pretty good example. So this is a bit much to get into during a general conversation, but you can go back and look at all these and see these are all very favorable things. So that's what I had about low-dose naltrexone. I think you guys already know about all the dosages. Dr. Clearfield's covered that in great detail and with his added wisdom of many years of actually prescribing it. And so I really can't do anything but add some technical things and leave the practical matters to him for sure. Oxytocin. Okay, oxytocin has a wide variety of functions, not just childbirth and milk production. When Dr. Halas began talking about oxytocin, we had 2 OB-GYNs in our panel that day, and neither of them were familiar with any of these functions. They were just simply not aware of it and not introduced to it. But it essentially has a lot of anti-inflammatory and immune control effects. It induces TNF-alpha, unfortunately. But it does inhibit NF-kappa B, IL-6, and cortisol release in response to stress and infection. In sepsis, we have a huge production of TNF-alpha, and oxytocin has been used to suppress that. So it's suppressive of TNF-alpha. It reduces the innate immune response by suppression of toll-like receptor 4. Look at that. We had 2 drugs in a row, right? Low-dose naltrexone and oxytocin, both suppressing the innate immune response through suppression of toll-like receptor 4 activation. We're inhibiting platelet aggregation, increasing endothelial nitric oxide synthase activity. We're upregulating PPAR gamma, which reduces the inflammatory responses in macrophages. And I believe PPAR gamma is also the target of curcumin. Then we're also decreasing the function of NADPH oxidase, which actually promotes the amount of NADPH available, because we're decreasing the function of an enzyme that breaks down NADPH. So we're leaving more free NADPH for fuel for mitochondria. It has cardioprotective effects, which probably are related to mitochondrial effects, and then reduces mast cell activation. So there's a whole host of interesting things here that can be used in patients with a variety of conditions. So oxytocin influences all of these systems: immune system, respiratory, metabolic, renal. I won't go through the whole list, but it essentially is a hormone that's present right at the time of childbirth in high quantities in females. And the purpose of it, in this is just my anecdotal summary of understanding, but during pregnancy, we want a few things. We don't want the mother to be sick, depressed, inflamed, in pain, and unwilling to nurse or care for her new infant. So it induces all of these, it kind of arrests all these inflammatory processes, temporarily at least, during that time after childbirth, to give the mother the best chance at health, to care for that child in those crucial first month or two. So that's why they call it the love hormone, or the, because it helps to connect the mother to the child in a bond, which we all know is a special thing. But there's medical reasons for that and evolutionary reasons for that. And so oxytocin is part of that system. So where are oxytocin receptors? They're in the brain, they're in bone marrow, spleen, thymus, and then these immune cells. Where does it come from? It basically comes from your pituitary gland, and it's secreted out to the body naturally. And interestingly, oxytocin induces its own further release. So a release of oxytocin to the body will also cause signaling back to release more oxytocin. So when you treat a patient with oxytocin nasal spray, or which is probably the best way to do it, you're putting oxytocin into the brain, and then it goes out from the brain into the body, or it can go directly into the body, but then it signals and induces its own production or release in the pituitary gland. But look at all the favorable things we have. We have reduction in IL-1, IL-1 beta, right? Interleukin-1 beta, that was the fibrotic guy. Interleukin-2, interleukin-6, TNF-alpha, NF-kappa B. Those are all the pro-inflammatory guys we dislike the most, right? Or a pretty good list of them. So we're reducing neutrophil migration, production of we're increasing IL-10 from Tregs. Okay, we're increasing the expression of PPAR gamma, so we're polarizing the immune system towards Th1. Just all these effects. So there's cancer-related effects, mesenchymal stromal cells. So I think there's just a lot to look at here with oxytocin, with regard to all the tissues that it affects. So nobody really seems to know much about that. So in ulcerative colitis, right? They looked at oxytocin as a potential treatment there, and measured that these types of changes to the cytokine signaling and inflammatory signaling in immune function are all regulated by this. And again, just kind of more effects. The oxytocin receptor is present in fatty tissue, and it helps to increase lipolysis, beta oxidation of fatty acids, adiponectin, increases insulin sensitivity and glucose uptake, increases hepatic glucose output, for better or worse, increases insulin secretion, beta cell responsivity to signaling, possibly beta cell regeneration. A lot of positive research being looked at there for an endogenous hormone. Dry eye is being looked at for dry eye. And this is kind of a mechanism that, where you can, or they're demonstrating that the causes and etiology of dry eye are impacted positively by oxytocin. Generally speaking, you'll find that oxytocin causes a little bit of increase in eye tears and nasal secretions. I've noticed both of those things when you use it. It's not dramatic, but you do notice it. And I actually, frankly, notice my eyesight's a lot better. It could well be because there's more tears and less dryness. It also may help in younger patients with neurological functioning in development. for those that have problems like autism and things of that. There's been, and I don't think there's any conclusions on that. I wouldn't go so far as to say that oxytocin treats autism in any way, but it is being looked at because it is an anti-inflammatory drug that can be administered by a nasal spray pretty much directly into this brain. And so we can have a lot of anti-inflammatory effects that would potentially be beneficial, but probably need more research. Now, does the oxytocin nasal spray get there? Yes, it does. It does that through the cribriform plate. And you can see here that we have the olfactory epithelium, and there's these olfactory sensory neurons. There's the trigeminal nerve and the olfactory bulb, both of which penetrate the olfactory epithelium and allow a pathway for migration of the oxytocin molecule along the junction between these neurons and the endothelial cells. That's not a tight junction. And so that can happen. The other thing is that there is a transport system, I believe it's called MRAGE, that can transport oxytocin through the epithelial cells and into the, I guess into the bloodstream or into the spinal fluid. So you can kind of see that picture here. The nasal spray is going up, it's contacting the cribriform plate, and it's proceeding through those neurons and the endothelium into the brain tissues. So, so the key structures involved with olfactory receptors that extend from the mucus layer into the olfactory epithelium. The olfactory fibers, we really kind of talked about this. These nerves are bundled. There's thousands of little tiny nerves, and because they're bundled like a rope, there's gaps around them, basically is what it is. You know, where things can penetrate through the cribriform plate. It's not a very efficient pathway, mainly due to anatomical barriers. I guess if you could reach up there and paint the cribriform plate with some kind of, you know, liposomal cream containing oxytocin, would go right through, but we're not able to do that because, you know, we're not able to access the cribriform plate directly. So it's probably about 5% bioavailable. So you can pretty much count on the fact that about 5% of your dose maybe actually reaches the brain. But studies have studied this actually and show that it's that's a sufficient amount to achieve clinical effects, because it's a potent hormone. Intracellular transport has an effect, but it takes hours, not minutes. So that's why they know it's getting through those nerve gaps. So that's why we looked at oxytocin as a potential treatment for anosmia, right? The COVID-induced inability to smell or taste. And we learned about this late in the pandemic, so I don't know that we really had a chance to try it for that purpose. But if those nerves being inflamed and damaged are the culprit for anosmia in that case, it would make sense to try oxytocin. It may have worked for that. So really, that's I think I've covered pretty much all of this stuff. But they have measured the oxytocin in the brain after administration of the nasal spray, and they do find it. Let's see. And here's just a quick picture of where, if you think about what illnesses could be treated with oxytocin, these are where the receptors tend to be. So there's various structures in the brain that have a high density of oxytocin receptors, and then large areas of the brain that don't apparently have much at all. So the effects that we see on mood and happiness and, you know, this positive mental effects from oxytocin are probably due to activation of the oxytocin receptors in the areas of the brain that handle those jobs. So kind of gives you an idea. And here's another, this is the last slide, I think, I don't know, it's not, there's one more, but it shows the flow of the spinal or of the I guess the fluid surrounding the brain, right? It circulates in an orderly pattern to perfuse all the tissues and come in contact with all the tissues it needs to. And so you can see that right here at the cribriform plate, you can enter that circulatory system And so it does actually cover a lot of brain tissues. So the studies that are done today, if you look in the literature, you'll find one of the biggest ones is sexual performance or sexual pleasure is impacted by oxytocin, although it doesn't work in a sublingual lozenge and it doesn't work in a single dose. You have to kind of take oxytocin on a regular basis. It's not something, it takes 2 or 3 days to kind of kick in. So if you're looking for sexual performance enhancement or pleasure enhancement, you know, you need to use it regularly. You can't just take it an hour before sex and think you're going to experience, you know, fantastic pleasure, because it really hasn't had a chance to do anything at that point. So I've learned that, and that's been why it hasn't worked very well in the past, by combining it with a Viagra or something like that. That doesn't really work. But if you use the nasal spray consistently and you take, say, tadalafil consistently, that would be an interesting combination for somebody that was looking to have a better sexual relationship with their spouse or whatever. So they looked at it for autism, borderline personality disorders, which I don't know if that has any treatment, PTSD. So basically inflammatory brain diseases, schizophrenia, inflammation in the body, neuropathic pain, weight control, dementia. So really, generally speaking, inflammatory diseases of the central nervous system are the primary target, and then maybe sexual enhancement. So challenging questions. We found out in the literature that you have to use a minimum of 24 units a day, pretty much intranasally, to have an effect. The max dose is 200. Nobody's ever done that I know of. But it seems like people get a good effect from 24 units once a day in the evening, or 24 units AM and PM. And I think, you know, for most people, that's a sufficient dose to get some kind of an effect. Now, how much more would you need to have an effect in a different patient for various purposes? That's hard to say. I think you just have to titrate it. And if you get to 100 units a day, you call it off if it's not having an effect, because it's not going to maybe be the right treatment. Oxytocin works differently when administered intranasally to the brain as opposed to peripherally by injection, right? We all know there's Pitocin injection. That doesn't do the same thing, because the roadway across the blood-brain barrier is kind of a one-way street. When oxytocin is made in the pituitary gland and it's secreted into the brain, once it passes across the blood-brain barrier, it's not very welcome back. It's like a 1 out to, or 10 out to 1 in. You know, it's like, so it's a 10x one-way street. So the oxytocin in the body doesn't come back and affect the brain, I guess, seems to be what's happening there. So the target tissue is deep in the nasal cavity. It's difficult to reach with a mechanical spray bottle. I think there could be a better way of delivering it, but I haven't figured that out yet. The nasal spray containers do work, but you know, that could be improved on somehow. I just don't know how might you do it. Let's see. Oh, yeah, spraying the anterior nasal cavity doesn't reach the brain, right? We have to get it to the cribriform plate. So it's important to make sure that patients don't have a deviated septum that would literally prevent them from spraying nasal spray into their sinuses and reaching their sinuses. So our chronic infections, problems that, you know, where basically we're gonna have trouble getting the drug to the target area, those should be all considered in the prescribing. But we do have quantitative evidence and studies that the drug crosses the blood-brain barrier and reaches the target tissue. And they actually have both quantitative and qualitative studies on that. You know, some showing effects, others doing measurements of drug concentration. But we've really had no serious side effects. I know a lot of people have asked if, you know, women had uterine reactions, or we have had no reports of that to my knowledge that have been reported to me. And and it's also, there's studies actually indicating it's safe for use in men. There was a long-term study in men, so it has been used in men without incident. Dosage and administration: 12 units sprayed in each nostril once daily at bedtime. 1 spray in each nostril at bedtime. And then if no response in 5 days, go to AM and PM, and then you can use your own judgment to go up from there. make sure the nasal passages are open and that the patient is actually, if the patient's failing, make sure it's not because they aren't able to spray it up their nose properly. And then the main side effect that we've been noticed is a drippy nose. Kind of you have to wipe your nose with the tissue here and there. It's kind of a liquidy secretion. It's not mucus or what we'd call snot, right? It's like more like a light watery effusion. So anyway, I thought that was an interesting bit about oxytocin that I hope you will find helpful. And I'm coming to my last drug, guys, so hang in there and we'll be done. This is one we've studied more recently. It's Amlexinox, another FDA-approved product that was approved for what at that time was called atopia. But, when we talk about atopic dermatitis, and atopia is essentially a Th17 immune disorder, I guess you would call it. So it's defined as a Th2 Th17 hyperpolarization that results in excessive IgE production in response to an antigen. That was a definition of atopia. That was not the definition of atopia when this drug was brought to market many years ago. I don't know that they really knew why it worked. They knew it did something to immune cells and, treated an immune regulated these aphthous ulcers in the mouth that I guess in some patients with consistent immune polarization in this manner, they can become so sensitive that basically the mouth is presented with antigens and an immune response that makes an ulcer over and over, just pretty much consistently all the time. So it can become a real problem. The people can not be able to eat, or they can have bleeding and infections, things like this in some cases. So why is Amlexinox not on the market today? I'll tell you why. It didn't make any money. You can treat canker sores or aphthous ulcers in other ways that are basically a lot less expensive and easier to do. And so the drug, just for its indication, didn't turn out to be a financial success. And so because of that, it was removed from the market by the manufacturer, but it hasn't been removed from the market by FDA or for any safety reasons. It just currently doesn't have a manufacturer. Because there's not really a known indication for it. So that's really what I think Dr. Joseph brought this to Dr. Halas's attention, and he had been working with this drug for some time and found it to be pretty effective. Now its main function is really mast cell stabilizer, if you want to look at it that way, but it has these other immune functions, and we'll go into a little quickly as to why. But it's under study for both inflammatory and allergic conditions, as well as type 2 diabetes and obesity. And that's because it's an inhibitor of tank binding kinase and IKK-E. And we're going to go over quickly what they do. But ultimately, we're inhibiting NF-kappa B, and it actually can inhibit mTOR. And it regulates macrophages, mast cells, and T cells. So ultimately, the effects of Amlexinox are on NF-kappa B, mTOR, macrophages, mast cells, and T cells. So what's it doing in each of these cases? Obviously, we inhibit NF-kappa B. We're basically downregulating the production of a whole bunch of pro-inflammatory cytokines and mTOR. We know what that does. Inhibiting mTOR, of course, this isn't like rapamycin where it's a potent mTOR inhibitor, but one of the concerns with Amlexinox could be that there would be some inhibition of mTOR. So I think that is one area we want to look at. It helps to regulate macrophage function, reduces mast cell or stabilizes mast cells, so reduces histamine output from mast cells and mast cell activation syndrome. So this would be a potential treatment for mast cell activation syndrome, especially if it's combined with these other immune polarization malfunctions. So stimulates AMPK. A lot of people are going to like that. And it helps with diabetes management, basically through stimulating the AMPK process. So interestingly, it stimulates AMPK and then has a slight inhibition effect on mTOR. So as we know, AMPK regulates mTOR. Tank binding kinase regulates the innate immune system in some ways. and inflammatory cytokine production, autophagy, and mitochondrial metabolism. So, so it's part of the innate immune system, in addition to our toll-like receptors and some of those other guys. And so it's just got its own regulatory set of things that it does. In the innate immune system, tank binding kinase mediates pathogen detection signals. So this is why it was used in aphthous ulcers, right? Person who you get a bacteria in your mouth, you have a hyper reaction to the bacteria because your macrophages are very hypersensitive to pathogens, and then they signal interferons that, as if, hey, we got a really severe infection, when there's really just a few bacteria present that are not, causing illness or at a dangerous level. It's also stabilizing mast cells when we inhibit tank binding kinase. So how does that work? Okay, basically what we have here is an antigen presenting cell, and it's approaching a naive CD4 T cell, and it's going, hey, I got a bacteria here. And then what happened is we get immune responses, right? We have IL-4, we have IL-18, and we have this whole host of stimulation of the immune cell, and polarization of Th2, right? So our naive CD4 cell wants to go to become Th2 cell. So we're going to be pro-fibrotic, right? We're going to be stimulating mast cells, okay? We're going to be stimulating eosinophils. And the mast cells are really the worst guys of the bunch, because what do? They make IgE, they make histamine. And those are two fairly nasty substances inflammatory wise. So these are kind of the destructive features of atopia. And so by inhibiting this process, we're inhibiting these things. So this is the allergic response pathway. This is not the effects of amlexanax, but by using amlexanax stops this process, right? Or inhibits this process. So what does that do for us? It helps us to regulate the innate immune system by suppressing the downstream effects of toll-like receptor 4. So now what we learn is, okay, we got a lot of activation of toll-like receptor 4. We don't like that. But rather, if we can block toll-like receptor 4, yes, but we can also block this tank binding kinase IKK system and block the downstream effects of any activated toll-like receptors. So we would really be tamping down toll-like receptor 4 signaling. And of course, this basically lays that process out. So we're modifying interferon production. We're inhibiting inflammation in all these various different processes. So that's the bottom line here, is that this by the tank binding kinase inhibition, and this IKKB is also inhibited its function. So that basically knocks out pro-inflammatory activities and signaling through NF-kappa B and all these other enzymes that are related to it that are involved in that process in this case. So, we got a wide host of pretty interesting effects. Cardioprotective effects. Amlexanax is shown to have cardioprotective effects. Proposed mechanism is inhibition of GRK5 mediated fibrosis and reduction in apoptosis. So we're preserving the health of cells. So a G protein is basically an intra or cell membrane pore that regulates catecholamines coming in and out of the cell. But basically, amlexanax suppresses this G protein RK5, and by doing so, I guess is suppressing catecholamine impact on the cardiomyocytes, and then reducing their propensity for fibrosis and these other downstream effects. So we're blocking all of these things at the same time. So that was something that came from the world of cardiology. In cancers, amlexanax is a potent kinase inhibitor and blocks phosphorylation of at least 10 protein and enzymes associated with cancer growth. And I am not an expert in all of these, but you can note that tank binding kinase and IKK, I guess that's E or sigma, I'm not sure what we call that symbol. But then all these other ones, but I am not familiar with, but many of you might be. The GRK1 lipoxygenases are things I've learned about. But essentially, this whole host of I guess tumorigenic kinases are inhibited by amlexinox. So it has some anti-cancer or protective effects. And this is kind of a reiteration of that slide, but basically by blocking all these various different kinases, we are reducing tumorigenesis and tumor growth. So, and again, tank binding kinase and IKKE process, they regulate these things. So interesting effects, so wide portfolio of effects. So it's easy to do. It's 3 times, unfortunately, it's 1 capsule 3 times a day because the half-life is short. The typical dosage is 40 or 50 milligrams 3 times a day. This is sold as a commercial drug in other areas of the world, but not in the US currently. So it's available through the compounding pharmacies have it. Amex stocks 20, 30, 40, and 50 milligram capsules. I'm thinking about working on a sustained release one you could do twice a day, but I'd have to do testing. It would take a little while. Also, it's useful topically because there's a lot of dermatologic conditions that can benefit from mast cell stabilization, and that is 2%. So far, we've had a number of patients on it, and we've had some good successes, and we've had some people that haven't reported back yet. So I don't have a lot to share in that regard, but this is a fairly new medicine that we've talked about, and really it's pretty much as safe as giving any other antihistamine or something of that sort. So I don't think there's a lot of downside to trying it. So in summary, that's really all I have for you today, which was hopefully not too much. But I wanted to draw your attention to the fact that a lot of these drugs just go together well because they're helping, they have synergistic effects between what they do. And I find that interesting that when we're looking for solutions to chronic diseases, we keep coming up with similar solutions, and little bits and pieces of it that different drugs do. But, we're always working against the pro-inflammatory effects and wanting to regulate things like autophagy and apoptosis and cellular senescence and oxidative stress and so all these things really together, I think create a pretty good arsenal to be considered for various chronic disease management. So with that, really, that was the presentation. So I appreciate your attention. I know that was a lot of information, and I went kind of quickly, but I don't want to put everybody to sleep by being 3 hours long. So I think.
Great job, Mike. Thank you so much.
Mm-hmm.
A couple questions in the chat. A lot of kudos. So where'd it go? What kind of treatment for uncompensated vestibular neuritis would you suggest?
Okay, let me get, pardon me for 1 second until I get my, okay, let's see.
Bring your guitar with too?
Oh, you can see that? I didn't stop my shirt. Yeah, that is me playing the guitar. Yeah, I've had a band for years, and that's me. Let's see. Oh, here we go. That's why I couldn't see you guys. Okay, good. All right, I wanted to get back to where I could see you. Okay, vestibular neuritis, right? Well, I don't have a specific treatment for that. I could look in the literature, but I think we could find some of the answers, in these medications here. Vestibular, I know oxytocin has been used to treat what do they call ringing in the ears? Tinnitus. And you have to use a fairly high dose because I guess it's a more difficult inflammatory condition to treat in some cases. But that might be one example. But I would have to look further in the literature for that particular.
Hey, Mike. Hey, Mike, can I contribute really quick?
Please, Dr. Dose, always.
Yeah, so Dr. Halasa had mentioned the idea of a oxytocin eardrop, and I hadn't found anything yet in the literature, but I was curious if you had any thoughts that, if you think it would absorb. I mean, I assume he said it because for a reason.
Yeah.
But yeah.
I heard about that, and yes, it is possible. And yeah, when you're talking about vestibular neuritis, I guess certainly an inflammatory medication applied to the external ear surely would treat some of that area. Presumably, we should have some absorption, especially if we did, a proper vehicle for it. I'd have to look further into it to be sure, and to really look at the drug delivery requirements to get the drug to the target area. Like, what are the barriers between the external ear and the vestibular apparatus? But I think it's certainly possible. Yes.
Yeah, and then also because I have I know of 3 people who lost their hearing. One of them I'm actually currently treating, so I'll be able to give some feedback. I'm also doing red light, sort of like red light earbuds or earphones, if you want to call them, at the same time. So I'm trying the oxytocin eardrops, 1 to 2 drops, 4 times a day, along with red light twice a day. And there's a handheld one. I actually tried it. It's good, but I like the ones that are like earphones, because that, then you don't have to, you can just do whatever you want to do and not have to hold your hand there. And then doing the oxytocin methylene blue nasal spray, especially the nasal spray, because according to the literature, its effects on the amygdala may be helping with the tinnitus part, or at least decreasing some of the oxidative stress of the nervous, sensory area. I don't know exactly the connection, but that's the approach I'm taking.
Yeah, I think that's sensible. And one thing I can tell you is that the use of the red light probably helps the penetration of the drug through, like, for example, the eardrum or something like that. It tends to help open barriers.
Right. So that's it.
Put the drops in and then do the light afterwards, or maybe do the light for a while, like 5 minutes, put the drops in, put the light in for 10 more minutes, that kind of thing.
Okay. So in Dr. Gordon's world, he uses something called Brain Care 3, and he said he's done a study, has an over 50% improvement rate. And it's a giant anti-inflammatory. It consists of maca, guarana, rhodiola, green tea extract, PQQ, coenzyme Q10, B1, B2, B6, B12, DHA, vitamin E, ascorbic acid, quercetin, and glutathione. That pretty much covers it all. It's all
a lot of polyphenols, a lot of things going on there.
It's all in one product. It's kind of expensive. Wow. And it's $92 for a month's worth. It's a little expensive, but that's his recommendation. So just
interesting. Yeah, that sounds very interesting. It's got a lot of the things we also have recommended in the past, but also some new things. So it'd be interesting to look at that.
Did you get this one a contraindication for methylene blue? That's the next question.
G6PD deficiency, right? If you suspect your patient has G6PD deficiency, you would run some risk of hemolysis, especially at higher dosages of methylene blue. It's not a horrific thing if it happens. If it were to happen, the patient will get like very dark urine, like like dark enough they would call you kind of urine, and that's a sign of hemolysis. Of course, we don't want to do that, but so if you can't check a G6PD deficiency on everybody, if you note like any dark, and I don't mean the urine turned blue, because of course we do expect that, blue, green, gray, those colors will all be present at times in the urine with methylene blue, but anything like really dark, I mean like almost like dark brown urine kind of thing, apparently can indicate the presence of hemolysis, and that would be the effect of methylene blue in a person with G6PD deficiency. So, but again, I think that occurs at high dosages, and I don't think G6PD deficiency is really prevalent, but it is prevalent among certain populations. So it just depends on your mixture of people that you're seeing. So I would leave that to you, but G6PD deficiency would be one contraindication. The other is methylene blue is a monoamine oxidase inhibitor. So any serotonergic drugs like SSRIs, especially the ones with super long half-lives like Prozac or duloxetine, those have the potential to cause serotonin syndrome. So I have a protocol to kind of help you decide. A lot of Lyme disease patients are on antidepressants and need to take methylene blue too. So I found some ways to kind of work around that a little bit. But that is also can be considered a contraindication, as a black box warning for that.
If you have that, I can put it on our website. I can pass it on to everybody. So
Would you like to know, I had a case, if you have time, I can talk regarding this questionable serotonergic reaction.
Okay, yeah. Hi, Dr. Patel, please.
How are you? So I had a patient that I gave her the low dose methylene blue. She tolerated, she said she had a little nausea. And then she was not on any serotonergic, any SSRI drugs. When we increased the dose, second time she was okay. The third time, she was okay in the office, but 3 hours later, she developed the vomiting, diarrhea, and she ended up in emergency room. And they told her that this appears to be, dehydrated her, but serotonergic reaction. But what she told me that she did, I asked her all the symptoms of serotonergic reaction, and she had, yes, nausea, vomiting, and diarrhea, but she did not have a flushing, because flushing is one of the very common symptoms of serotonergic reaction. She did not have abdominal pain. She did not have so many other symptoms. I have a list of symptoms, except what I mentioned. But then she was kept overnight in the ER, and the next day she went home. But she said, I have never felt as good in my life as what I am feeling now. I've been sick for the last 10 years, and
Oh, you muted yourself, Dr. Patel. You're muted right now.
I'm sorry.
Oh, that's okay.
So
we hear your last sentence or so.
okay, so she said that I after I went home, I felt so good that I've never felt so good in my 10 years of my life. This is the first time I'm feeling so good. So what to make out of it?
That's
I don't know.
interesting.
But I don't think that it was a serotonergic reaction.
It's very uncommon under 1 or 2 milligrams per kilogram.
No, I gave her probably a dose of about 20 or 25 milligrams.
Yeah, it's very uncommon at the.
It was IV. It was IV dose, okay?
Yeah, so that could have crossed the blood-brain barrier rapidly, and maybe like been
No, she had it over. I mean, I'm very particular about not giving it. It's and I give them on 500 ml bag. I don't give them 150 for the simple reason, so they can, even if we are not there, and if they turn it off faster, it still takes good 2 hours.
Mm-hmm. Yeah. That's interesting. I don't know. I'll think about that and keep that in mind, because it is interesting. If anybody has a case like what Dr. Patel describes, I would love to know more about it, because especially some of these patients that are very, very ill that would benefit from methylene blue, they are an antidepressant. And we probably most from what I understand, these serotonergic reactions aren't common in general practice of medicine, So it may be something that patients and doctors could miss if they didn't know what they were looking for, or might overlook it or attribute it to something else. So I would like to learn more about that, and I would be happy to collect information. I don't get any reports similar to what I've heard from you today, Dr. Patel, but I always have my ears open for those things, and I really do talk to a lot of people about it. So I will always keep my ears open for that.
And I give them the photodynamic therapy. After photobiomodulation, photodynamic therapy, whole body laser. So many times they complain of pain where the IV really was distributing. So that is the time that I decided to go for 500 ml. And since then, they do not have that complaint. So whatever, because I think in one of your notes, I saw that slides, I saw that suggested that use the 5% glucose in 250 ml. But if they are going to use a higher dose, more than 10, 15 milligram IV, then they may monitor the patients for pain. And if they have a pain, then the following time they can increase the volume.
That's great advice. Yeah, so we would want to go to a larger bag, and yeah, it makes a lot of sense. So what we're saying there is that in a 250 bag, maybe your max dose is 20 milligrams or less, and so I can kind of make that add that to the notes in the protocol that you know, kind of according to your comments. That's a good idea.
Yeah. One more question here, Mike. Can LDN cause dizziness? Yeah, pretty much anything.
I mean, I wouldn't say no. I don't hear reports of that. The main thing that I hear, and Dr. Bill, really, you're the expert on low dose naltrexone. I don't.
What do you hear?
The only thing I ever hear about is insomnia, you know, or sleep kind of disturbances for the first few days, you know, and that's
some transient nausea, and the literature says 20.3% of the time, vivid dreams, which is nightmares.
Yeah. So some might call that insomnia or sleep disturbance, bad dreams, any of that above.
Yeah, well, usually we like to dose it at night so that you know, by the time we wake up in the morning, your endorphins are loaded up and ready to go. But there's like a whole protocol to back down every 2 hours from bedtime if you have sleep disturbance. But I've just made it easy and said, if they get a sleep disturbance in the first, usually it'll happen in the first night or two. I just tell them to take it during the daytime, and then that usually takes care of that.
Okay, that's good advice. Yeah,
practical simplify our lives.
Yeah.
So, okay. All the rest of the chats, unless there's any new ones, say have a great evening. Thank you so much. Great class. Well worth listening to. Great job, and you know, the usual Mike Boehmer praise. So
I really appreciate that. Thank you, guys. And I'm always here to help. And it's always a great learning experience to share it with you guys because of all the great comments you get. You know, over the next day or two, various people will call me and we'll chat about these things. And, you know, that's how we push the ball forward a little bit. Mm-hmm.
Anybody?
Can I contribute my 2 cents?
Go ahead.
Okay, well, for years, I've had nasty canker sores, sometimes on my tongue, under my tongue, on the side of my cheek. And I collected an assortment of canker sore remedies. And I used to use a product when it got really bad called Canker Cover, that you put it on and would form a good covering and maybe help heal it for a couple of days, okay? And then, you know, I use lysine, clove oil, different types of essential oils. But then after the COVID episode, I got trigeminal neuralgia, which is like electric shocks from hell. I mean, you can't eat, you get it in the back of your head, you get it behind your eye, you get it inside your nose. And I tried a lot of things and nothing worked as well as Amlexinox. So it's like a gift from heaven. And I am always grateful to Mike, Dr. Joseph, Dr. Halasa for, learning about it and trying it. And it also gives you a sense of well-being. And I noticed that after the COVID, it negates a lot of the fear and anxiety and a lot of things that affect your mind. So I thought it's terrific stuff. So I can only speak from my personal experience, but like, wow. I mean, it's like I never had the electroshocks, like they never existed. And to go from one state to another is phenomenal.
That's great. Glad to hear that you did well like that. That's awesome.
Yeah, and thank you.
If you'd asked an experienced acupuncturist, though, they would tell you that a single needle, large intestine 1 on the opposite side of where the lesion is works wonders, and usually takes the pain down in less than 10 minutes, and the lesion's gone usually within 48 hours. So I've been
Are we
doing.
talking about a canker sore or the trigeminal?
Yeah, both.
Oh, interesting.
Yeah, I've
Wow.
been doing it for 30 years.
Wow.
What's the
Acupuncture's
point
fascinating.
called?
Large intestine 1. I don't know what it is in the opinion or
Okay.
but it's at the medial nail angle of the index finger, and you
Well, I had a search and stim, like, finds an acupuncture point and puts in a stimulation, and that helped with the pain too. I would put it on the tips of a couple of fingers. I would try things in my ear, and I experimented. When I found something that worked and helped, that was great, because I could take NAC, I could take glycine, I could take some other things that would help, but nothing worked like Amlexinox.
well, good. Well, it's good to know too. So we'll do it as a synergy, right, John?
That's right. Hey, I've been kind of saying the simple thing that the benefits of prednisone can be similar to the benefits of Amlexinox without the side effects. Is that a too far off saying, or is that pretty true?
I would, it's hard to know about the action, and that's a good question that you're raising, is how do we find a good substitute for steroids, right? And this gets debated a lot in the dermatology world because, of course, they really rely on steroids quite a bit. And, I think it can. I don't think it'll have the high potency of like a good stout dose of, shot of Dax or something like that to relieve, back pain or some, acute inflammatory condition. But I think over time it could have a similar effect. Yes, but I think it would take time. Like a lot of our what we call functional medicine therapies, they're slower and they require more persistence, but they don't have that punch. But that's why they don't have the side effects. When you have that punch, that means you're doing a lot of other things to force something to happen. So I think it's a more natural way of relieving inflammation. I think methylene blue, I think Amlexinox, I think really all of these drugs we talked about tonight in some way or another have that effect.
Thank you.
Okay. Well, that's all the questions in the chat, and
Okay. Well, I know that was a long presentation, so thank you for your patience. I appreciate
thank you.
Thank you.
We'll put this up on our website, aosrd.org/webinars. If you haven't seen it, we have all of our srd.org/webinars. We have all of our videos on there. We've been at this for 2.5 years, still going. Next week we have Dr. Nario, one of our local doctors, is going to be presenting for us, and I could be wrong, but I think this is his first time presenting, so we'll have to go easy on him. Okay.
Make sure he knows Zoom.
No, he'll be fine. He'll be fine. So, okay, everybody. The end of the week, if anybody's interested, Nevada Osteopathic Medical Association, I'm going to be doing a talk Thursday night on non-hormonal ways to manipulate hormones.
On Thursday, I actually got a call today that a doctor wants to know non-natural hormone treatments for menopause. So this would be good for that. Thursday.
Thursday, it's 5:15 Pacific, it's 8:15 Eastern. Go to Nevada Osteopathic Medical Association, and there is a Zoom, and it is CME credits too. So Thursday night, and then Friday morning, I'm doing a 4-hour workshop on women's hormones from A to Z. Everything you need to know about women's hormones. It's going to last about 4 hours, so cover everything. So, and it's a full conference too. I mean, I'm not just me. So, but that's the end of the week. If you're interested, Nevada Osteopathic Medical Association, and I think there's 25 credits. It's AOA credits. If anybody's interested. So I think I put it in the email last week too.
Great. That sounds awesome.
Okay. Questions, comments?
You know,
What do you got, John? What do we hear from the medical school?
Everything is good every way, and this lecture of Mike tonight is a reminder of what this group can do and what we have to share, because it's hard to get this information in the standard street.
Right. So
Amen.
we've also gotten, by the way, just to let you know, we've gotten some interest. I didn't see them on here tonight, but we've gotten some interest from some medical students from Philadelphia College of Osteopathic Medicine. And they've actually asked to be on our mailing list, and they've been asking about certain topics. So hopefully we're making some inroads with some young people.
Good.
They'll have hair.
Yeah, it's rebels.
And by the way, where's Dr. Lass? Is still in Libya or
Yeah, he's in Libya. I don't know what he's doing.
some exotic place? I haven't heard from him in a while. So
Yeah, he's in the desert out there.
okay. Well,
You can get him on WhatsApp. He'll answer.
yeah, okay. Last time he was there, didn't his phone get stolen or something?
Yeah.
It was on video too. He sent us a video of his phone.
Yeah. They had the guy on video. They're like, "Do you think we're gonna look for him? You're crazy. Go buy another phone."
Okay. All right. Well, anybody that runs into him or hears from him, tell him we miss him, you know. So, okay. Dr. Joseph, thank you for your contribution, and Shell also. Everybody here, please, thank you so much. Please bring one person. We will double our census. And we'll see you next week, same time, same station. If anybody's has any questions or comments, please let me know. You all know how to get me. And John here, with Dr. Bill,
Bill,
email.
Bill.
Yep.
They have you down for what is it, hormone parallel track tomorrow morning at 8. Are you doing that?
Tomorrow morning? I hope not. I'm still in Reno.
I know, but I'm just looking at the schedule.
It's supposed to be Friday morning.
Oh, okay, because they have you down for tomorrow.
Well, I hope not.
Well, you know, be in 2 places at once.
Yeah, well, okay. I mean, I can do it from here, I guess, but I got customers.
Okay.
Okay, so.
Yep.
Thank you all, and good night for me. Okay.
Yeah, Mike, thank you. Thanks for hanging in there. I know it's late back east.
No, I'm thrilled to do it. I appreciate it. It was good to see
All right.
everyone.
Take care, everybody. John.
All's good. Thank you.
Hey, John, while I got you on here, I'm
All
gonna
right.
turn off the video.